Hello.
Yeah, I can. Sorry, I think the problem was at my end. I am going to. What I have decided is that I'm going to cover a bit of liver, and then I'll go to pancreas, and the main part of liver, hepatobiliary, we will cover next Thursday. So that's the plan. Now, high speed. Now, once again, this is a case of trauma. What's happening? Over to you.
So these are selected contrast enhanced axial images of the upper abdomen for a adult patient. There's multiple hypodense linear areas throughout the liver, most likely in keeping with acute liver lacerations. I can't see any active extravasation of contrast on these images. Okay. But there is an impression of some free fluid around the liver.
Okay. The idea here was to, when in trauma world, the description is that we two words can be used. One is laceration when they are linear like this, and there is another word which we call intramural hematoma. So these are the two words. It is good that you were looking for any extravasation. Active extravasation is in the exam, usually they show it. Is there any active extravasation here?
Yes, I can see it on the second and third images. There's a blush of contrast.
Excellent. So in this case, what is happening that there is trauma, and we can see that there are splenic lacerations and a lot of hematoma there. But the key finding is this one here. There is intramural hematoma, and with that, there is extravasation. So the viva questions will be around this. Once you pick that up, because this becomes an emergency, and the role of interventional radiology now, because they would like to do it conservatively, so the interventional radiologist can help with embolization, and they might ask you question, how will you do, which kind of materials can be used, etc. This is another case where you can see that splenic rupture and active extravasation. So always keep that in mind. Okay, what is happening in the liver parenchyma?
So these are selected axial images of a CT scan in the arterial phase. There appears to be contrast within both the arterial and venous system. There's also quite a lot of periportal hypodensities or edema.
Right. So the basic idea is that, arterial and venous system, of course, that's not the issue in this case. The issue was just to develop your eyes on this finding, which is what we call periportal edema. Now, sometimes what I have seen is that inexperienced, ST2s, let's say, they at times they confuse this finding and they think that this is intrahepatic, biliary channel dilatation. If you go back to your anatomy, what's happening? That portal vein, always remember that the biliary system is anterior to the portal vein, anatomically speaking. It cannot be posterior. Here, what is happening? That anterior as well as posterior, you can see this hypodensity. And this is what we call periportal edema. In your latest Chapman, this is the differential 8.14. Periportal edema can be hypoechoic on ultrasound, hypodense on CT, hyperintense on MR. Basically, we are talking about a circumferential halo around the portal vein. So it will surround the portal vein, and there are so many causes. A patient might have hypoalbuminemia and will have it. And a patient might have acute cholangitis and will have it, or cholecystitis will have it. Similarly, in trauma also, you can see it. So the idea is just to pick up that this is what is happening, periportal edema. So totally non-specific. Okay, now what I'm going to do is that I am going to skip the liver component. And as I have told you that the plan is to come back to the liver and the biliary system next time. Okay, over to you, candidate 5.
So these are selected axial images of a contrast-enhanced CT study through the upper abdomen for an adult patient. There is a large abnormality in the spleen, which appears to be of fluid density with a thick enhancing rim. On the third image, there's also the impression of some internal contrast enhancement.
Yeah, actually, this is a bit of motion artifact. So,
okay.
So this is just calcification. So what will be your differential then?
So for a cystic splenic lesion, my differentials would include a splenic cyst, a pseudocyst, or an abscess perhaps.
Means if it is calcified means that there was an abscess in the past. This is what you are trying to say?
Yes.
Okay. So basically, the idea here was to cover the cystic, the differential diagnosis of cystic splenic lesions. Pseudocyst is the most common, post-traumatic, etc. Sometimes you don't even have a history. And epithelial cyst, abscess, hydrated cyst, etc. This is just to cover the differential. And similarly, there is a differential diagnosis of solid lesions in the spleen, and the most common benign, and it can be divided into benign as well as malignant. Most common benign lesion, solid lesion, is hemangioma, and it will behave just like hemangioma of the liver, which we will cover next time. And most common solid malignant lesion is lymphoma, and also metastasis is up there. So this is the list from your book. Solid splenic lesion, non-neoplastic, benign, malignant. So the idea is just to cover this. This case has got calcification in the liver. Candidate 5, can you give me the differential diagnosis of calcification in the liver? Causes. That is the idea of this. Do you remember anything? Candidate 5, are you with us? You've lost her. Yeah, I think we have lost her. Okay, so thank you, candidate 5. Candidate 6, can you raise your hand, please? Candidate 6, are you with us?
Yes, hello, Dr. Han. Can you hear me clearly?
Yes, I can. So just give me a bookish differential diagnosis of calcification in the liver.
Okay, maybe mucinous tumor metastasis.
Mm-hmm.
Maybe fibrolamellar HCC.
Mm-hmm.
Maybe hydatid, although this does not look like hydatid.
Mm-hmm.
There's nothing else on my mind, but my first differential in this case is mucinous Smith's or pseudomyxoma peritonei even.
Okay. So the idea here is just what can be, just to cover the calcification, and there are so many things which can calcify in the liver. And our case there was metastasis, and this was in this territory, mucinous metastasis, maybe from colon. And these are calcification within a mass like metastasis, fibrolamellar HCC, but there are other causes which are given here. So I am skipping the liver part for the next time, and we will come back next time. So we go to the pancreas actually. Yes, please.
So there is marked swelling, edema, and fat stranding surrounding the pancreas, the entire pancreas. I'm searching for any areas of non-enhancement. I think it's most of the pancreas is enhancing.
What do you think? Compare this versus this.
Yeah. The body is slightly hypoattenuating in comparison to the tail.
So what does that mean? What does that mean?
Process, acute necrotizing pancreatitis.
Okay, well done. So when you see a case of acute pancreatitis, you must comment on two things. One of the things is visible on this case. Are there any non-enhancing parts of pancreas? Because that means that there is necrosis going on. I'm not going into staging, etc., because various centers use their own staging. But having said that, you have to point out that X part of the pancreas does not enhance in keeping with necrosis. And the second most important thing in acute pancreatitis is visible on this case. Over to you. This is a different case, please. Candidate 6, over to you.
Yes. Okay, so I can see air foci in the region of pancreatic head, which is also hypoattenuating in comparison to the rest of pancreas. So this is acute infection in the context of necrotizing pancreatitis.
Okay, so what do you suggest then? What would you like to do? How will you manage this case?
Yes, these cases usually needs surgical debridement and of course antibiotic therapy.
Right, so you can put in a drain before the debridement, right? So the point is that the first take-home point from this case is in acute pancreatitis, you have to look for any signs of secondary infection within that fluid around it. And if you see an air bubble there, call it. Simple as that. And in this case, there are multiple bubbles. And then, in these kinds of cases, they will ask you to put in a drain, and you can also offer, you can say that I'll offer to put in a drain. And then there might be some questions regarding interventional radiology. Over to you.
Okay, this is ERCP image with contrast filling the pancreatic duct. I can see evidence of surgical eclipse, possibly resembling cholecystectomy.
So this is unrelated, and I'm not interested.
All right. So I cannot see the body or tail of pancreas.
Excellent. Well done.
In my normal practice, I tend to measure the common bile duct to make sure if it's dilated or not.
Okay, that's fine. I'm not interested. Please remember the bile duct is up to 1 centimeter post cholecystectomy is taken as normal, but I'm not interested.
All right. So
I'm interested in what's happening here.
There is abrupt termination of the pancreatic duct.
Mm-hmm.
Maybe there might be a tumor compressing the duct, maybe a congenital anomaly.
Okay, what kind of congenital anomaly do you think of?
A pancreas divisum.
Okay, excellent. Now, if you just concentrate on this, pancreas is developed from two buds. One is known as the dorsal bud, and second one is the ventral bud. The dorsal bud has got the main pancreatic duct, and actually it has got its own, technically speaking, an opening, accessory ampulla. But this is the ventral bud. The CBD comes with it. Normally, what happens, it crossovers and sits here and then joins. You remember we also did a case of annular pancreas. But having said that, once it joins, now it is sitting here. The duct of the ventral duct is known as Virsang. I remember it with the symbol of, the Volkswagen VW, ventral Virsang. So this is how I remember it. Now, usually there can be many patterns. Usual pattern is that it joins with the main pancreatic duct, the dorsal bud. And one pattern is shown here, where this thing also, the duct of Centurioni has got its own opening. Another pattern will be where this completely obliterates and there is only one opening. So all of these are possibilities. Pancreatic divisum is what is shown here, which is self-explanatory, that the duct of Virsang has, it just ends here, and it is not in continuity, and means that there will be two ampullas. And this is from literature, one MRCP examination showing the same thing. Pancreatic division is associated with chronic pancreatitis. So at times the gastroenterologists, they like our comments on that. Yes, candidate 6, over to you.
All right, so these are axial CT images with oral contrast. There is lipomatous transformation of the pancreas. The most common pathology to do this is cystic fibrosis.
Excellent. So here, in the exam scenario, this kind of a case becomes very difficult to pick up because, something is absent and the human mind does not go into it. And basically, the pancreas is not there. It is all, there is just fatty, atrophy. And usually it can be seen in patient of cystic fibrosis, and it can also come in the exam as a long case.
Okay, so these images in the venous phase show marked dilatation of the intrahepatic biliary tree. And there is also dilatation of the pancreatic duct. This is a double duct sign. So there is actually a heterogeneous, predominantly hypoattenuating mass at the region of head of pancreas. So this is, in conclusion, it's a pancreatic head adenocarcinoma with double duct sign, and this patient needs urgent drainage for this biliary system.
Okay, well done. So here what is happening is that this is the pancreas, and the pancreatic adenocarcinoma attenuates less than, it's a hypovascular tumor, so it attenuates less than the pancreas, and with that it is causing obstruction of the pancreatic duct, as well as the CBD and intrahepatic duct dilatation is there also. So now we will go into the world of pancreatic tumors, and this is from your book. So many things can happen, but I will confine myself to some of the important ones from the exam point of view subsequently. Now, one point of technique which I want to elaborate is that pancreatic parenchyma enhances, maximum enhancement of pancreatic parenchyma is actually at 50 to 55 seconds. It's not a classical arterial phase. It's not a classical venous phase. It is somewhere in between. And hepatic phase is 65 to 70. Now, point to remember is that pancreatic adenocarcinomas are vascular lesions. So, literature tells us that if you want to pick up a tumor, you can use this phase and your sensitivity of picking up a tumor can increase. It's more of a theoretical knowledge these days, not a practical knowledge, because we do not use, CTs to pick up a tumor where it is not visible. Which modality is the king there? Candidate 6 for pancreatic, pancreatic tumor which are not seen very well on CT, and you are seeing, let's say, a abrupt cutoff of a duct, or you are worried about a tumor. Then what modality will you go for?
MRI, thick cuts, maybe.
No, king modality there. So hint, something like esophagus.
And then endoscopic ultrasound.
Yeah, endoscopic ultrasound. So in esophagus, you remember, and this is a viva question, when you do T&M staging, for T staging, endoscopic ultrasound is routinely done. In pancreas, it's slightly different. You don't have to do an endoscopic ultrasound to pick up to do T staging, which I'm going to teach you on CT. On the other hand, if a tumor is not visible, endoscopic ultrasound is much better, and of course you can do a biopsy with it also. So first of all, this is a case where you can, just to make the point that this tumor, this is a 70-second delay and this is a 50-second delay, and you can see that the parenchyma is enhancing better, and you can see the tumor is better seen. Having said that, nobody does it. The king modality is EUS, and EUS, if you see that if the tumor is less than 2.5 centimeter, CT is 53% sensitive, EUS is 89. And on the other hand, if the tumor is larger, generally speaking, EUS is about 98%. So EUS is the king modality, and this is viva question. Here is an example where there is a bit of duct dilatation, and you practically very difficult to pick up a tumor, but on EUS you can see the tumor there. Candidate 6.
Yes.
This is abrupt pancreatic duct cutoff. What is the significance of this sign?
And it can represent a tumor.
Yeah. So I warn you that this is one of the most important signs where you see a double duct sign is very easy because both ducts are dilated and means that the tumor is quite big. But I have seen many cases and many discrepancies in my life where this sign was missed, and retrospectively speaking, the patient had this sign. So if you see a portion of the main pancreatic duct dilated, you have to raise this issue. It should be discussed in MDT. There's a bit of differential diagnosis because the patient might have chronic pancreatitis. That's a different word. But the patient might have a tumor, and an endoscopic ultrasound might be the savior there. Okay, now as far as T staging of pancreatic tumors is concerned, the key thing to understand is T4 tumor. T4 tumor, look at it. You see, let me go back to first of all T3. So T3 tumor is tumor extends beyond pancreas. What is the definition of beyond pancreas? Surrounding structures including duodenum, stomach, colon, and spleen, but without involvement of the celiac artery or the SM. But if there is involvement of celiac artery or SMA, it becomes a T4 tumor. Take home exam point is that if celiac artery or SMA is involved, T4 tumor means non-operable. And this is what they are going to ask in the exam. So pancreatic tumor, pancreatic carcinoma is another carcinoma of the concepts of which you should know for your 2B exam. So I'm going to teach you a bit more about it. So please remember, for head of pancreas pancreatic carcinomas, classically, or neck of pancreas, we do Whipple's. Of course, if the tumor is in the body or tail, we can do different type of surgery, and in which we do choledochojejunostomy, and then we can do gastrojejunostomy also. What does it tell you? You know, inherently, if the tumor has gone into the duodenum, you can simply remove the duodenum with the tumor. So it will still be a T4 and it will still be operable. And in the exam, you have to tell the examiner why a vessel is involved or encased or infiltrated. The criteria here is more than 180-degree interface between the tumor and the vessel. Please remember that the criteria, we also learned the criteria in CA esophagus vis-a-vis descending aorta, and there the criteria was different. Interface more than 90-degree was abnormal, or means was positive. Between 45 and 90 was a gray area. Less than 45 was fine. But here we take 180 degree. Now look at this example. This is the tumor, and look, this is the vessel. This vessel, by the way, is SMV, superior mesenteric vein. And you can see the interface, and this interface is less than 180 degree. Look here. There is a tumor here, and it has got interface here, but this is less than 180 degree. On the other hand, look at these two examples. The tumor, it is surrounding more than 180 degree. Here, it is surrounding more or less 360 degree. So these are positive. So a slight difference between esophagus and pancreas in this category. And other signs which are also taken as signs of invasion, if a vessel is flattened like this, or there is a tumor thrombus, then you also say that this is abnormal. So these are the signs of vascular invasion. Please remember that historically speaking, if the superior mesenteric vein was involved, maybe 20 years ago, that was also considered inoperable type of a tumor. But now, surgeons have developed skills. It all depends where you are working, because they can remove the superior mesenteric vein. They can put in a graft, and usually up to 1.5 to 2 centimeter long grafts can be put. There are many technicalities. But the take-home point is that if a vein is encased, it is not taken as absolute, contraindication to surgery. It might still be possible. On the other hand, celiac artery and SMA are involved, then there is no hope. No surgery can be performed. This is a case where this is the celiac artery, and you can see that the tumor is completely encasing it. Take home, this is a very important slide where it tells you that if the SMA and celiac artery is involved, it is inoperable. If duodenum or spleen is involved, don't worry. Why? Because if spleen is involved, you can just do splenectomy with pancreatic surgery. Borderline tumors are these ones where the superior mesenteric vein or the portal vein or the splenic artery or the stomach and colon are involved. Look at this diagram here. The splenic artery is involved. So what can be done? That there can be surgery, just cut the splenic artery here and do a splenectomy with it. So these are known as borderline. I don't think so they will ask you anything in this world. They will ask you if the SMA or the celiac artery. So if I'm an examiner and I want to show you a pancreatic carcinoma, I'll show you something encasing SMA or the celiac artery, just to check your concepts. Okay, from here, we go back to the classification of pancreatic tumors, and we have got solid tumors, and we have got cystic tumors. Now I go to candidate 7. Can you raise your hand, please? Thank you, candidate 6. Are you with us, candidate 7?
Yes.
So now we have got solid tumors and we have got cystic tumors here. So first of all, among the solid tumors, there are 2 types. One is pancreatic carcinoma and second is pancreatic neuroendocrine tumors. The concept is that the pancreatic neuroendocrine tumors can be benign as well as malignant. Extremely important for the exams, and I'm going to show you what can be asked in the exam. Now, first of all, candidate 7, can you tackle this film? So I've got an ultrasound image here, and I've got just one, late arterial phase, early portal venous phase type of a scan. Over to you.
So I'm presented with spot images from ultrasound scan and CT scan with arterial phase of a female patient with hypoglycemic attacks. On ultrasound, I can see an abnormal hypoaquic rounded lesion within the head or at the junction of the head and body of the pancreas. There is no significant ductal dilatation that I see on ultrasound. On the contrast CT, just where the normal vessels are at the junction of the head and body, I can see another hyper-enhancing area rounded in configuration.
What is your conclusion? Well done.
So my conclusion will be a hypoaquic mass on ultrasound, which is showing contrast enhancement in the arterial phase in the pancreatic body. So it would be a hypervascular solid tumor, which in pancreas are most likely the islet cell tumors or the neuroendocrine tumor cells, which are hyper-enhancing.
Excellent. So what we have learned from this case is that the 2 categories of tumor, one is what we call neuroendocrine tumors. They enhance. On the other hand, pancreatic carcinoma does not enhance. Now, if you see this chart, the neuroendocrine tumors can be hyperfunctioning and they can be non-functioning. But this concept is extremely important to remember. What are the rates of malignancy? And you'll be surprised to note that all of them can actually degenerate into malignant tumors. The minimum rate is insulinoma, and that is also up to 10%. But it can be, more than that. And look at some of them. For example, ACTH-OMA, 100%, more than 90. So carcinoid is one of them. And they can be non-hyperfunctioning also. There are a lot of viva questions. Many a times they come in the exam. If you see what is written here, these are important points for you to remember. They can be, insulinomas can be part of MEN1 syndrome. Gastrinomas are very important for the exam. Concept to remember, they can be 60%, multiple in 60%. Concept of gastrinoma triangle is a key exam concept. Please remember that gastrinomas might be within the pancreas and they might be outside the pancreas, within an area which we call gastrinoma. So if you, and then because they can be multiple, you might pick up one, then the examiner is expecting you to pick up another one. And they can also have, part of MEN syndrome and extrapancreatic in 15%. All of them can have malignant potential. So basic idea is that if you pick them up, you do a bit of biochemistry, even if they are non-functioning, you can infer that they are, because of their enhancement, that they are neuroendocrine tumors. Venous sampling, etc., very seldom is done these days. At times, the patient is offered surgeries just on the basis of CTs. At times, there is a bit of role of nuclear medicine also. We will cover the nuclear medicine aspect of it in our session. but usually you don't sit on them. You just get rid of them. Of course, in the real world, you know at times you don't, because the patient is elderly or the patient doesn't want surgery, etc. So these are the various kinds of questions, etc., which can come in the viva. Another thing is that another difference with pancreatic carcinoma is that calcification is much more common. So they can have calcification. Please remember that adenocarcinoma of the pancreas can also have calcification, particularly because they might be associated with what we call chronic pancreatitis. But per se, tumor calcification is much more common in neuroendocrine tumors. And this is the gastrinoma triangle. And this, you have to remember this. And you can understand that an examiner will show you a tumor, which is, this is the duodenum and it might be sitting here. And your eyes will not go there. So you have to remember this gastrinoma triangle. Zollinger-Ellison syndrome, where there is a gastrinoma. Here it is sitting here, projecting into the duodenum. And with that, there is thickened rugal folds. This is the differential diagnosis of thickened rugal folds. I also showed you a case of Zollinger-Ellison previously. Okay, candidate 7.
Okay, so this is one of the magnified spot images from a contrast-enhanced CT scan axial slices. So there is a rounded lesion with the enhancement pattern almost similar to that of the pancreatic parenchyma, and it appears kind of exophytic from the tail of the pancreas. I can consider this to be a pancreatic neuroendocrine tumor. However, in this location, I should also be looking for any other lesion which can give this kind of appearance, or a normal variant maybe.
What is the normal variant?
I can think of splenunculus.
Right. Well done. So accessory spleen is a normal variant, and please remember that embryologically speaking, spleen can there can be various portions of spleen in this region. And it has been, so many times I've seen that it has been wrongly interpreted as a neuroendocrine tumor. So keep your minds open. And this has come in the exam. And there is another scenario which I'll show you in the next slide, which has come in the exam more commonly. So point to remember is that on all sequences, the enhancement pattern will be equal to spleen. So what we do nowadays is that if somebody has reported it like this on a CT scan, just to confirm it, we do an MR. And it's simple as that. On all sequences, the lesion will be equal to the spleen. If you see an MR of the spleen, you will see that the diffusion weighted shows a bit of restricted diffusion. It is inherently bright on DWI spleen, and that is a very useful sequence to compare it. So that is a normal variant, accessory spleen. This case, beware of this, and this has come in the exam many a times. And this is slightly different than an accessory spleen. This is known as splenosis. Basically, ectopic splenic tissue then growing up. So these patients usually have got previous history of, let's say, trauma where there is a splenic rupture. Now the splenic tissue has gone right and left within the abdominal cavity. And later on, they just grow. And when you do a CT or an imaging, you are worried about a mass. Another thing is that many a times post-splenectomy, you will see it. And I've seen one case which was very interesting, which was a gunshot wound years ago. and the splenic tissue was sitting in the thorax, just like this one from STAT DX, where something is sitting next to the heart. And so splenosis is a very, very important exam case. And if you don't know it, your mind will not pick it up. Yes, please.
So I'm presented with a CT scan axial slices at the level of pancreas and kidneys, which shows a large, well-defined cystic attenuation lesion within the body and tail region of pancreas. There is slight, it is thin-walled, and there is very, very mild enhancement, maybe like anteriorly. The differential diagnosis for this would include pseudocyst, less likely an abscess, or a cystic pancreatic tumor would be in the differential as well.
If it is a cystic pancreatic tumor, which tumor?
Most likely mucinous, because they tend to occur more in the tail region. And I do not see any calcification on this one, but they tend to have mural and peripheral calcifications. So if there is one, it would suspect me more for mucinous.
Okay. So in your Chapman, cystic pancreatic lesions are given. I'll give you a slightly smaller classification of tumors part. But please remember that the most common cystic pancreatic lesion is a pseudocyst. And pseudocyst, by definition, they will occur maybe 6 to 8 weeks after acute pancreatitis. So classically speaking, in the viva, you have to tell the examiner that I'll correlate with the previous history. Is there any history of pancreatitis, etc.? But many a times you will see them incidentally. Also, there is a concept of true cyst in the pancreas. Some people think that this concept is not actually correct, but others feel that there can be true cyst. For example, in one Hippel-Lindau's disease or autosomal dominant adult polycystic kidney disease. And a pitfall is duodenal diverticulum, where this is a case of autosomal dominant polycystic kidney disease. And with that, there can be cyst in the liver as well as pancreas. One Hippel-Lindau syndrome we will cover in our CNS module, where you can see that there is hemangioblastoma of the cord, hemangioblastoma of the cerebellum. Here is retinal vascular tumor of the right orbit, with that this cystic lesion in the pancreas. So one Hippel is a very important case. It can come in a long case also. Duodenal diverticulum. So the key thing is, don't confuse it with a cystic lesion. Now, the final thing in the last 20-25 minutes is to cover these cystic lesions. And candidate 7, I'll give you just one more case, and then candidate 8, you should be ready. Now, if you see this, cystic lesions, or should I say cystic tumors here? So not lesions, but tumors. Can be serous cystic neoplasm, mucinous cystic neoplasm, intraductal papillary mucinous neoplasm, and solid pseudopapillary neoplasm, SPM. Now, there is a concept that this mucinous as well as IPMN, these two can be benign, but they can convert to malignancy. Benign and convert to malignancy. Serous cystic, on the other hand, is just benign and there is no malignant potential. This one, I believe, is beyond 2B level. I don't think so anybody should ask you in the 2B. But I put it here just for completion's sake because it's a very interesting tumor. It is seen in young patients, 20-year-old females, and it's a very unique type of a tumor because of the age group, etc. They are always malignant, but the prognosis is quite good actually. Okay, this is your last case, number 7. Can you tackle this?
Okay, so I'm presented with a spot image from the CT abdomen with arterial phase contrast enhanced. There is an obvious abnormality, most likely in the head or body region of the pancreas, which appears multi-cystic with cysts of various sizes. I would measure, like in normal practice, how the largest cyst measures. And then there is a speck of calcification, a coarse calcification in the periphery. So since we are doing the pancreatic cystic tumor, so this most likely can represent a cystic tumor with a calcification. So could be serous cyst adenoma.
And why not a mucinous cyst?
Because the mucinous, they tend to have larger cysts, and the serous tends to have like smaller cysts. There is a criteria, I think 2 millimeter or 10. I'm not sure. I've forgotten that.
Okay, well done. So, is there any malignant potential if it is a serous? If you are right, is there malignant potential there?
No, as we just said that the serous are mostly benign in nature.
Okay, thank you. Number 8, you are next. Number 7, you can mute yourself. So, now, what are the take-home points as far as serous cystic neoplasm? So, if you see, first of all, these pictures, and you can make your radiology from here. First of all, a disclaimer is that in real world, at times we cannot discriminate between the two. But if you see a classical picture, and the examiner has to show you a classical picture for you to be able to pick that up. Now, this picture tells you everything, that it has got multiple small cysts. One thing which in radiology we give a lot of leverage is outline of the tumor. If the outline is lobulated like this one, you see the outline, it is lobulated. And why is it lobulated? Because there are multiple small cysts sitting there. On a CT scan, at times you cannot see the walls of the cyst, but the lobulated outline tells you that there are small cysts. Look here, and you will agree that the outline is lobulated. Classically, the central part will have calcification, but all of these things are, with a pinch of salt, because everything is not classical in many cases. Now, they are slow-growing benign lesions. This is important. 75% in women, mean age is 62. So that is why we call it grandmom tumors. So 62 years. And they can be sponge-like and honeycomb appearance. Lobulated outline is one of the way to describe it in the exam. If there is calcification, it will be usually central, and it can be only seen in 18% of cases because there is a scar here and there is calcification in the scar. The disclaimer is that at times they might be composed of just one or two cysts, and that is what we call the oligocystic type. What is the management? The management is that usually we do follow-up scans for these patients, but of course it all depends on anatomy. If it is more than about 4 centimeter, if the clinical presentation, if the location, we might do surgery. But remember that there is no malignant potential. This is a case on MR, and here if you see on the T2, you are not very sure if you are looking at small cyst. But if you look carefully, look at the outline and it becomes a bit lobulated. On MRCP series, you can actually see multiple small cysts. So these are microcysts, and mucinous tumors usually have bigger cysts. Candidate 8, are you with us? Okay, can you hear us?
Yes, I can.
Okay, there is no history of pancreatitis. Over to you. What is this?
So in the body of the pancreas, there's a homogeneous, well-defined lesion with an enhancing border. The pancreatic duct doesn't appear to be dilated. I cannot see any calcification. And the patient does not have a history of pancreatitis. So my differentials would include a mucinous cystadenoma, given that it's quite homogeneous, well-defined, and predominantly centered on the neck of the pancreas.
What are you going to advise for the patient?
So if this is the first CT, I'd probably recommend an MR to ensure.
How will an MR help you?
Well, it might help narrow down the differentials if it's something else, such as a pancreatic collection or any other lesions, and it can also help define the internal structure of the cyst.
If you want to see inside, EOS is the king modality, and MR is not going to be helpful. You will be where you are. With clinical correlation, there is no history of pancreatitis. This looks like a cystic lesion with smooth outline, single cyst, call it a mucinous tumor. And these kinds of lesions, you cannot sit on them. You have to. So basically, this should be discussed in an MDT. And then you can make, do you want to do something, you want to do aspiration and confirm it, or you want to offer surgery, because please remember that they can degenerate malignantly. So if you see these pictures, and this one has got calcification, but this is peripheral. So the concept is that mucinous cystic neoplasm can convert to borderline tumors and then to carcinomas. The age group is slightly younger. So mean age group is 47. Remember, the serous tumor, the age group was mean 62. So that is known as grandmom tumor. This one is known as mom tumor. And exclusively in women. So some of the other, this is women, that was 75% women. So classical appearance is that it can be unilocular or it can be multilocular, but the cysts are going to be larger, and it can be very large also. So body or tail is more common. Smooth outline. You remember the outline of the previous one was lobulated because of small cyst. This one has got smooth outline, and the calcification is going to be peripheral. Signs of malignancy. What are the signs of malignancy? If there is wall thickening or irregularity, or there are mural nodules. To keep it simple, think like an ovarian cystic lesion. You remember that in an ovarian lesion, if there are thick septations, enhancement, nodularity, enhancing nodule, you call it a malignant tumor. Management, all should be removed, ideally speaking. But in the real world, everything is not ideal. But having said that, you should understand that this has got malignant potential. This is a very, very good case. And over to you. Then I'll tell you the story.
Okay, so this is a portovenous CT of the upper abdomen. There is a well-defined cystic lesion arising from the pancreas with a slightly irregular border. The lesion is homogeneous, well-defined. There appears to be some calcification within the posterior to the lesion.
That was in the vessel, so arterial. Don't worry about that.
Okay. The mass appears to be causing some local mass effect on the stomach, and there also appears to be thrombus in the main portal vein. Having a look at the liver, I can't see any associated liver lesions. There appears to be some fat stranding, posterior medial to the lesion and adjacent to the pancreas. And I think around the pancreatic head, there appears to be a hypoenhancing focus.
What is the conclusion?
So given that there's a hypoenhancing focus in the pancreatic head, I'll be concerned about a pancreatic tumor, an adenocarcinoma there. The cystic lesion, I'm not sure if this is a separate entity and represents a mucinous cyst adenoma with a pancreatic adenocarcinoma.
Or you're very, very close.
Is there a complication of the pancreatic adenocarcinoma?
Yeah, absolutely. This is malignant transformation of mucinous cyst adenoma. And basically, if you see here, it's a very good learning case. And what happens is that we missed it. And there is a scan which I'm not showing you, which was about 7 months prior to this one. Similar findings, closer, now these are more blatant. Basically, if you see here, there is a cystic lesion. And how did we report it? We just reported it that this is it, this is a cystic lesion. Is there any history of previous pancreatitis? Because the reporter thought or raised the issue that this might be a pseudocyst. Actually, then it was missed. If you look carefully, look here, there is an enhancing septa inside. In a pseudocyst, there can be debris, etc. The outer wall of a pseudocyst can enhance, but there should be nothing enhancing within the cyst, number one. Number two, look at this soft tissue. And this soft tissue actually is encasing the celiac axis. This is classical tumor. And that tumor is going into the portal vein also. So this is a very good case, malignant transformation of, so you'll just say that this is a malignant mucinous cyst adenocarcinoma. This is another case where if you see there is a cystic lesion and you can see all of this enhancing septi and some nodularity, again you will raise the issue that this is a malignant, what we call adenocarcinoma. What's happening to the pancreatic duct, main pancreatic duct, and what is the differential for this?
So the pancreatic duct is grossly dilated, and I can't see a specific transition point. I can't see any intrahepatic biliary duct dilatation. Differentials for this can include pancreatic adenocarcinoma, main branch IPMN will be the top two differentials.
Pancreatic adenocarcinoma, why did you say that?
As a differential for the dilated duct.
So you mean to say that the pancreatic duct is dilated and I am worried that something is causing this dilatation, and whatever it is, it might be within the head. So that is why you said it, right?
Yeah. Okay.
But the counter argument will be that if in this location there was a pancreatic duct, adenocarcinoma, so much dilatation, by now there should be double duct sign also. This is the distal end, right? But coming back to the differential, you said other than that, main duct IPMN, what did you say?
Yeah, main duct IPMN.
Okay, very good. Chronic pancreatitis can also cause dilatation, but in chronic pancreatitis, you will see a beaded appearance and you will see calcification, which is a pertinent negative in this case. So that will be a pertinent negative. Main duct type IPMN is, as the name tells you, that this is a mucinous neoplasm which arises within the main duct. And if you do an endoscopy, you will see mucin coming out like this if you are an endoscopist, and the concept is that main duct type IPMN can also convert to a carcinoma. So you have to be careful. other than, unlike the first two tumors, this is more common in males, and this is at the age of average age 65. I call it the granddad tumor. So there was a grandmom, there was a mom, and this one is a granddad tumor age-wise. And it can be main duct type, it can be branch duct type, and it can be combined. This picture from radiographics tells you everything. So if it just involves the main duct, you see it is going into the ampulla, opening like this. If you are an endoscopist, you will see this mucin coming out. It can be branch duct type, where the branch ducts will be continuing, or they will be in continuity with the main duct. Histologically, it will always be visible, but radiologically at times it will not be visible. And it can be, multiple, this bunch of grape type of appearance. They can be larger also. So these are the various patterns which you have to remember. This is a branch duct type IPMN, very common finding, this one, without any main duct type IPMN. This is a multifocal branch duct type IPMN. You can see this, and you can see multiple branch duct type IPMNs. This, I don't think so they will show you in 2B. It's just an incident loma. But main duct type IPMN, you have to remember for your exam. Combined tumors are also there. So this is the main duct, and these are the branch ducts which are dilated. So what is the risk of malignancy? Main duct type 57 to 92%, branch duct only 6 to 46%. So main duct type, you should be worried about malignant transformation. What are the signs of malignancy? Pancreatic duct more than 9 millimeter, mural nodules, or signs of invasion, frank invasion. Main duct type surgeries can be offered, but I have seen so many patients who have refused surgery because it's a big surgery and you just sit on it. I've seen a case which was diagnosed in 2006, and I think 2018, 12 years down the road, it just blew up into malignant transformation. So it's a big subject in pancreatic imaging, how to manage and things like that. Luckily for 2B world, whatever you need to know, we have covered that. This is malignant transformation of a main duct type IPMN, where you can see that this is the main duct, and actually right now a stent has been passed. You can see that there is a tumor sitting here. So this was the classification of solid and cystic. The only tumor which is less is solid pseudo-papillary neoplasm. So just a recap, in the solid, we have covered pancreatic carcinoma and pancreatic neuroendocrine tumors, and they can be benign and malignant, and they enhance and they show more calcification. And we have covered gastrinomas, etc. Cystic neoplasm, serous cystic neoplasm is that grandmom tumor, no malignant potential. Mucinous cyst is the mom tumor. It has got malignant potential, and intraductal papillary mucinous neoplasm, which can be main duct, branch duct, and mixed duct, again malignant transformation. This tumor is a rare tumor. I don't think so it can be asked in the 2B exam, but just for your interest, I put it here, solid, and just to complete the list, solid pseudo-papillary neoplasm. It's a unique neoplasm which is extremely rare, almost always women, and average age is, look at this, it's too young, 20 to 30 years, and that is why it's become new. If you see a cystic lesion in a young age group lady with a solid component, just call it solid pseudo-papillary neoplasm. It has got solid enhancing and cystic component, usually body and tail. It can be very big, up to 11 centimeter, and it is malignant, but interestingly or luckily, quite indolent course, and 5-year survival is up to more than 95%. So, serous cyst, grandmom tumor, mucinous cyst, mom tumor, SPN is granddaughter tumor, and IPMN is more males. So I call it the grandfather tumor.